This will be the last presentation for the day. And Vicki Marsh is going to be presenting on behalf of the other KEMRI team linked to the AHOS study. So over to you, Vicki.
Thank you, Maureen. Thank you very much. I've got my video on for a few moments, but I'm just going to start by noting that I'll need to turn it off because I've got very poor bandwidth in the part of the country where I am in the UK at the moment. I trialed this with Kai and it was taking a long time just to change slides if I have my video on. So I'm going to turn it off, but I just wanted to put it on to say hello to everybody. And perhaps just this first bit to say my huge thanks to all the people who are named on this slide who have been behind the 2 REACH case studies involved in Kilifi and Nairobi, or involved in Kenya. 2 particular people I want to mention here is Mary Kimani, who is very closely involved in a lot of the data collection, as was Anderson Charo. But Mary, unfortunately, is not able to join us today because it's a good reason. She's studying for a master's in the UK at the moment. And the whole rising of COVID at the time that it did meant that, that timing hasn't worked out. So she's not able to join. And the second person I wanted to give huge thanks to is Amina Abubakar, who I hope has now joined us and who is the head of the neurodevelopment program in Kilifi and the PI on the AHOS case study that I'm going to talk about on behalf of this team. I don't know if anybody, Kai, can you confirm if Amina is there, or Amina, can you give me a shout if you're there? Unfortunately, when I'm sharing slides, I can't see the gallery view anymore.
Vicki, I don't see her, but I'll keep an eye out.
Okay, all right. Okay, so my video is going off now, and I'll continue. So you'll recognize this slide from one of the early ones that Sassy showed, and I'm really going to be able to benefit from the background that's already been given to you for the chain study, particularly for the context that was set for Kilifi, which is in coastal Kenya, because that's the site for the adolescent health outcome study as well, in which this second empirical research ethics study was embedded. So just in the way that Sassy described, there are a set of objectives for REACH in relation to these embedded empirical studies. And in the case of the Adolescent Health Outcome Study, or AHOS, this is, to give you a background to that, this is a study that focuses on public health burdens associated with perinatally acquired HIV infection in adults in coastal Kenya. And the particular recognition here is that children who are perinatally infected are surviving into adolescence, which is obviously a really good thing. But there are kind of increasing recognition of specific health issues for this age group in relation to chronic comorbidities. And AHOS was set up specifically to look at the impact of perinatal HIV on adolescents who are living with HIV's executive functioning, so educational outcomes, medical adherence, and health risk behaviors as well. So AHOS is an observational cohort study. So in that sense has many of the kind of inherent ethical problems that Sassy and Jay and Rita described for chain. The study procedures themselves is that a total of 600 adolescents are involved in this study, aged between 13 and 17 years. And as I mentioned, this is coastal Kenya. And that 600 includes 200 who have perinatal HIV infection, 200 living in families impacted by HIV, but who are not themselves infected, and 200 who are uninfected and not directly impacted at all. And the study procedures for all of those adolescents who are involved in AHOS is that they should visit the Neuroassessment Research Centre at the KEMRI Wellcome Trust Research Programme in Kilifi once a year. And that's about a half day's visit without travel in the study for a 2-year period. So that's 3 visits for half a day over that period of 2 years. And during the visits, the main study activities involved a clinical examination Sometimes some of those clinical examinations were also accompanied by routine blood sampling. And then adolescents would complete a self-administered computerized assessment of neurocognitive functioning and health risk behaviors. And there were also some direct interviews, face-to-face interviews with adolescents and also with their caregivers on scholastic experiences, outcomes, and socioeconomic indicators for the particular family. AHOS sits within a much wider program of studies on neurodevelopment issues in this part of the world. And over a long period of time, the research group have set up a relationship with both in-house clinical resources and also linkages to health and social care services in the public sector that support the ancillary health and social care needs where those are indicated. So obviously there are some problems in that area, but this is these linkages for support within the public sector are very well established for this particular program. So on the next slide, we've already talked about this. I'm not really going to kind of dwell on it at all. We've talked about vulnerability, what we're thinking about here in terms of an increased risk of incurring harm and the paradox that's concerned with that. So I'm going to just go past that. In this particular study, we found it really, really helpful to draw on Florencia's theoretical lens on vulnerability as layers, both from the 2009 paper that described the layers of vulnerability as multiple, variable in time and space overlapping, but also from her more recent, or your Florencia more recent paper in 2018, that describes vulnerability cascades through the interactions between those layers that generate a process, recognizing that the presence of a vulnerability cascade seems to give particularly marked responsibilities to researchers to act in different ways. It's also very helpful to this presentation that just before the break, we started to talk about researchers' responsibilities because that's much of the focus of our analysis at the moment. But in both papers, there is this idea that mitigation strategies require a very fine-grained analysis of different kinds of vulnerability layers. And this photograph is a photograph of a typical primary school in Kilifi County. So in the empirical ethics sub-study that we ran as part of CHAIN within AHOS, we kind of drew on this idea of layers and thought about the different areas of adolescents' typical life and the forms of vulnerability and resilience that might emerge in those. And so we thought very much about sort of the individual being at home in relation to family, extended family community, attending school, because in fact all the AHOS participants were in school, and also in accessing healthcare, particularly the comprehensive care clinics for adolescents who are living with HIV. We also thought about the sort of wider context, socioeconomic context and policy context, government and non-government, and thinking about all of these layers, what then happens when you join research? What's the extra layer that's added there, and how does that sort of overlap with other experiences? So this was, Luna's paper really helped us to visualize a way into our study. I'm not going to say very much about methods in the interest of time, but I'm really happy to come back and talk about this more. The one that I wanted to mention is that our choice of methods qualitative sub-study didn't add yet another layer of vulnerability to an already vulnerable population. We wanted to try to design something that would be, if anything, empowering rather than undermining. So we ran this study over 3 phases. In the early phase, we talked to a lot of different key stakeholders in education, research, and social and healthcare policy and services. And we also talked to a small group of adolescents living with HIV who were themselves acting as adherence champions in their own CCCs. So relatively resilient young people and their caregivers. And off the back of that data in our first analysis, we then held a participatory one-day workshop with 24 participants in AHOS who were adolescents living with HIV who had been perinatally infected. And in that workshop, our primary focus was to kind of talk about experiences of participation in AHOS, and only secondarily how that linked to other areas of their lives. And following the analysis of that stage, we came back to do further data collection over a 3-month period the year before last now, in 2019, mostly re-interviewing or reconvening group discussions with people who'd already given data, so that we could explore the issues that were emerging. So that was the process. And over the rest of the presentation, I want to talk about the findings and particularly relate that to the way that we've begun to think about what responsibilities that generates for us as researchers. Although I would say that this raises more questions in this presentation, again, because of the time issue, we're not really able to share all of our data. And so we focused on rather a narrow area within our data in relation to 2 themes that seem particularly important. But when we reach our, not quite conclusions really, but when we move on to the discussion, what we see is that what we're presenting there actually is relevant to all the findings that we have so far. So first off, much of our data points to the fact that adolescents living with HIV are autonomous and resourceful young people, but they experience many interrelated challenges across the domains that we've looked at. And again, this is a secondary school, in fact, a picture of a typical secondary school in Kilifi, and a meeting being convened, not a normal class. And here I wanted to present our findings in a way that relates to Florencia's idea of a vulnerability cascade across these areas. So these 3 interlocking circles are supposed to try to highlight the way that these influences feed into each other. First off, from the individual home and community sphere, secondly, from a school sphere, thirdly, from a CCC, comprehensive care clinic sphere, and then finally, the kind of impacts that might have on physical and mental health and education, recognizing that this cascade looks like it's going down towards increasing vulnerability, but anything that moves things in the other direction, of course, would promote resilience. So it's sort of which way is this going to go? And I want to start with the top circle on individual home and community, and just talking about a few findings there. So we learned about a risk of psychosocial challenges associated with the adolescent period, as well as living with HIV. I'm just going to touch on a few core areas here concerning the way that HIV status was disclosed, and concerning a whole range of issues around the way that the family, the nature of family, peer and community support. Particularly important was the existence of positive role models in the family and experiences of either support or discrimination in the extended families. And the high rate of orphanhood in this group was a particularly serious problem, particularly where poor or elderly grandparents or reluctant relatives became primary caregivers. So those sorts of influences set the background for individual risks of stigma, and that would be exacerbated by obvious features of ill health, such as delayed growth. And if we look at the school setup, what we found in schools was that the risks to privacy were particularly marked and seemed often to be related to micro-level policies on accessing antiretrovirals or getting time out of school to attend CCC. And that would particularly be the case for boarding schools, which would impact some primary schools and also quite a lot of secondary schools. So, for example, a common micro-level policy was that all students should hand over their regular medications to the school matron for safe storage and to supervise all their treatments. And to support this, in some schools, bags might even be searched publicly on the first day of term, tipped out, and dormitory spot checks undertaken. So it's very difficult for students to maintain complete privacy around their need for regular medication. Some students, many students, tried to hide their ARVs, but then they would need to take them in secret. So that would also lead to issues with adherence, because it's very difficult to find a private place in a school. And similarly, students are required to provide evidence when asking for time off school to attend CCCs or any other clinic, and were asked to show a doctor's note on return. And so faced by these kinds of challenges to their privacy, a common strategy on the part of adolescents living with HIV was just to leave school without permission, which sometimes involved accepting quite harsh physical punishments on return, including caning or tough gardening tasks. And some adolescents described these actions in ways that reflected some degree of agency, but obviously highly constrained norms. So the next slide, I've just got a quote so you get a sense of the kind of data I'm talking about. He says, "I just started at that school the other day. I'm still new. And from the way I find them," and he's talking about teachers here, "it's like they're rumor mongers. So I won't say, I'll just go to CCC, come back, get caned, and the story ends." So if we turn now to the CCC appointments, the major risks here were really the time taken and an experience of encountering blame for ARV non-adherence in CCCs, particularly because staff were often working in highly resource-constrained settings. So it's important to say, first of all, that NASCOP, which is a National AIDS STD Control Programme in Kenya, is a really active and progressive body with a strong commitment to youth-friendly services at CCCs. And an example of a NASCOP policy is that to counter the time burdens that young people experience when they're attending CCC, particularly those who should be in school, if they wear their school uniforms to the CCC, they should be prioritised for services. But in practice, adolescents were often forced to wait many hours at CCCs. Sometimes staffing challenges generated that kind of problem. And sometimes it was actually a punitive response on the part of staff to adolescents attending on the wrong day. So for example, if they chose to come on a different day because their existing appointment clashed with an important school event, even an exam, for example. So, and in addition to that, a particularly challenging experience for adolescents emerged through a very common micro-level policy to check individual accounts of antiretroviral adherence through counting the number of pills remaining at a booked follow-up appointment. So if too many pills remained, in contrast to those that were supposed to have been dispensed at the prior appointment, adolescents were assumed to have missed doses and again could be severely reprimanded. So I'm going to just go on to the next slide again to just show you a little excerpt from a group discussion with 3 adolescents talking about this problem of pill counting. And the first adolescent says, "The one at the pharmacy, if you go there with a lot of drugs, they will quarrel with you so much. I don't know what. It's like you're teaching us scolded." And their friend, a third one, chips in, "Even if it's only one remaining." So you get quite a strong sense of the unfairness of what's going on here, or perceived unfairness of what's going on here. And similarly, a loss of weight or increased viral loads on testing, particularly where associated with too many pills remaining at follow-up, could lead to teenagers being accused, sometimes harshly, of non-adherence. And the unfairness of this blaming led to distress and anger, which in turn made some young people decide to actually stop taking their antiretrovirals or refuse to attend particular CCCs, but instead to move from clinic to clinic, incurring increasing inconvenience in time and travel that could further undermine follow-up. But it's important across both of these domains, school and CCC, to recognise that individual staff attitudes were really critical influences around the way that these risks might work out. So we heard really moving stories of matrons or teachers in schools and staff in CCCs who acted as HIV champions and supported adolescents living with HIV in sometimes extraordinary ways. But if we go back to this diagram and look at the bottom circle, we see the way that adolescents' experiences in everyday life, home, school, and CCC, with the particular areas that we focused on, include risks to privacy and acts of discrimination, generating further risks of ARV non-adherence, loss of schooling, social isolation, and impacts on physical and mental health, as well as educational opportunities. And so across these pathways, we see the way that vulnerability can deepen as a cascading process, with one insult being piled upon another, but also, as I mentioned at the start, the way that resilience could be supported, driving this pathway in the other direction. And this would turn perhaps on the way that a policy is enacted, or the choice of an individual at a given time to support or to blame. So if I move to the next slide. Here, I want to just consider what is it that happens then when teenagers like this join a study like AHOS. Are there risks of increasing vulnerability? Is there any support for resilience? And on the left-hand side, what we're looking at here is that time and privacy risks in attending research clinics might be a kind of cumulative burden. In other words, that risk is already there, as described in the previous slide, as a potential component of a vulnerability cascade, so that any additional risk that's encountered through research participation needs to be seen in that light, not as a risk in its own right, which seems actually really very limited. A half a day, once a year, 3 times, seems a relatively limited time risk, and many efforts were made within AHOS to minimize any privacy risks. But it highlights the importance of looking at these things as cumulative burdens. So when we look at the right-hand side, I've just put one point here and I've got more on the next slide. But firstly, there were a number of minor complaints about aspects of the study, but there was a really important emerging sense in which adolescents from our data seem to enjoy the experience of being involved in AHOS. And the main reasons underpinning that was the experience of being respected and listened to, as well as having a positive opportunity to interact with peers. So on the next slide, I've just got a quote again. These are two, I couldn't choose, so I decided to give you them both. First of all, I have a young man saying, "They, the staff at AHOS, keep secrets. At the beginning, you will be told there is no one who will know whatever you have said, and it's true, no one knows. It's only you and the computer and the doctor. You feel very good." It's a really important point about privacy. And the second one is from a young woman who says, "Whenever I go there, I feel happy because they treat me nicely. When you go there, everyone is free with you. There is a way you can ask someone something and their reply is cold, that I will feel afraid and even think of not coming back. But since they, at Cambridge, treat me nicely, even as I say hello to their phone calls, I immediately dress up and go." So the respect. And coming back to these two boxes, in relation to the support for resilience, apart from the appreciating respect shown by research staff, it's interesting to notice it's a really extraordinarily high retention rate in AHOS over time. Over 97% of teenagers remained in this study. I don't know if Amina's on the call, she'd be able to give an up-to-date figure on that. And one wonders, we don't have data to support this, but there is a sort of hint within our data that to some extent, that positive experience does something to counter some of the discriminatory attitudes encountered in everyday life, potentially even a means of countering internal stigma. And certainly ancillary care support that was provided was largely appreciated, although almost inevitably there were some shortcomings in the kind of support that could be provided. So that was not an entirely positive response, but the support that was provided was appreciated. And so on my last slide then, I just want to offer some thoughts on researchers' responsibilities in situations like that encountered in AHOS. And again, noticing that while the analysis is drawing in a subset of our data, these arguments seem to apply across all. And fundamentally, we're following a prominent set of arguments in global health research that researchers should move away from a narrow or procedural account and towards a wider and more situated account that includes recognition of structural forms of inequity and impact potential participants and research participants and communities. So this is really taking us to the point that I think we got to before the break, but trying to add an additional piece here in terms of considering the extreme nature of some of these structural and interpersonal burdens that research participants may be facing. So in relation to the narrow account, we've already described the way that within AHOS is designed to address disabilities. So for example, minimizing time here, drawing on the engagement opportunities that Sassy referred to that forms the sort of support across the Camry Wellcome Trust programme in terms of designing studies, both through relationships with the county level health and social care policymakers and providers, but also through engagement directly with communities to think about how these studies should be planned. During the course of this study, there was in fact an opportunity for our team members of the schools engagement programme at Camry Wellcome to talk to some school students about this kind of study. That wasn't done at the start of the study, but provided some learning along the way. So from a wider account, I've talked here now about the collaborative partnerships that underpin Camry Wellcome's activities. And I just really wanted to kind of emphasize that supporting responsivity in terms of designing and conducting research, but also in fitting within relevant national policy frameworks so that we can look for potential future social value from these studies. And that I think we've already begun to touch on from this morning's presentations. And I also wanted to add here that these are the same kinds of collaborative partnerships that could enable researchers to actually work with others to directly address some of these structural and attitudinal issues that are at the heart of risks of vulnerability cascades in our study, or seem to be in our study. So that's in relation to resources and relation particularly to attitudes at CCCs and in school environments, responsibilities and capacities to actually work in this way through the partnerships that they have. And finally, just recognizing then that collaborative partnership seems to be an obligation for this kind of research involving vulnerable individuals. So it does seem to say something really important about the context and what needs to be in place to support this kind of research being done in an ethical way. And that I'm using the word obligation as a direct recognition of the risk of vulnerability cascades, which Florencia has described in her paper so well as really heightening the kinds of obligations that the researchers might have to act. So the very last slide is just to show acknowledgements clearly to all the study participants, particularly wanting to recognize Amina and Mary, but also all the other people who've been involved and all the other institutions that have supported this work. Thank you. Should I stop sharing now?
Yes, please.
Thank you, Vicky. Sorry about the, there were some sound fluctuations, but we could hear you just fine, Vicky. Just for everyone else, she doesn't normally talk quick, slow like that. A quick question that several people asked was, what is CCC? Could you just factual question?
Sorry, I did say it very quickly and didn't link them properly to the acronym. So that's the Comprehensive Care Clinic. So those are the regular clinics that people who are living with HIV would attend.
Okay, thank you. So I thought what we do is we could start out for questions for Vicky and the AHOS team, if there were any direct questions about about this session, then we'll come back around to the other questions that we left at the break. Did anyone have any pressing issues related to the AHOS study?
Lauren, I'm just really keen to kind of see whether Amina is here
I
now
don't
to
see
see whether she wanted to
Amina.
add anything. You don't see her? No,
I
okay,
don't think she was
right.
able to connect.
No, okay.
Kai, let us know if she joins. So maybe what we could do is, oh, sorry, Sassy, go ahead.
Well, no, it was just a point, Vicky. I know we've discussed this work a lot of times, but I just, as you were presenting there, I think another thing that occurred to me is how crucial the interpersonal handling of or interrelationships between frontline research staff and community members can be. So in particular, in relation to the positive engagement with AHOS and some of the, adolescents talking about that being a positive and potentially even having an impact on their own internal stigma, is that it's a really, perhaps there isn't always enough attention given to supporting staff with communication, with management of emotions, with the interpersonal handling with participants, and sometimes more directly on, how do you explain what the research is, etc. So it was just a thought.
Yeah, I think that's a very good point, Sassy. And I think, particularly for this team that regularly work with vulnerable adolescents and children, and obviously working with healthy participants, which gives you a little more time and less pressure of kind of clinical services to be delivered. So there are things about the context here that made that more possible, and it clearly emerged as an important feature of the study for the participants.
So Vicky, Jenny Morrow had a question, which was how the team handled the difficult finding about the physical punishment, the caning reports from young people.
So this is where I wish that Amina was on the call. I mean, this is clearly something that would need to be sort of fed back through the study in which we were embedded. We've had conversations with, or much as with Chain, but perhaps in a slightly less embedded way. We have had regular communication with the AHOS team all through to report back on our findings and to let them know what's going on, what's turning up in our findings. I think one of the difficulties has been that the sort of interruption of research activities, particularly the interruption of the analysis of our data, and we had a little more data that we were supposed to collect that we haven't been able to collect, has meant that, we're still working on this analysis now and wrapping it up and beginning to draft our first manuscript. And so we probably haven't fed back quite so in depth on these findings until we'd brought everything together to know a good way of trying to kind of give that feedback in depth to the team. There have been district sort of health stakeholders meetings all the way through in which we've given sort of overviews of what we're finding. So I think I would have to say that at the moment, that's unresolved, how that should be fed back. That's a school policy. It's a general school policy. And so I think my own personal view on that is not that, we could be kind of trying to change school policies around caning students if they're absent from school without a reasonable excuse, but to look at the ways in which clinics and students or the attitude towards HIV in schools and in clinics could be shifted so that it would be possible for students to say, I'm going to a CCC and here's the note, without risking forms of enacted stigma.
Thank you, Vicky. Koi, did you want to chime in on this?
Yeah, and I don't have like a response, but I'm just, I guess, putting it out there, Vicky. I'm curious about this school policy of caning children, because to my knowledge, physical discipline is now not legal in Kenya, like in the classroom. So if this is a school policy, I think they're actually breaking the law. And then it raises another question for us as researchers, when we encounter these kinds of ethical dilemmas, then how do you manage that? Like when, it's the same case as if you're in research and then someone reports domestic violence or gender-based violence within the home, then, what do you do with that sort of thing? So just putting it out there, I could be wrong, but I'm pretty sure it's not legal to physical discipline is not legal anymore in Kenya in terms of schools. But I stand corrected.
Yes. Okay, well, Koi, I would be interested to follow that up with you. I mean, we have, as I mentioned, reported these findings to the district health and social care stakeholders forum, which supports the AHOS study. So I think we need to just investigate that a little bit more closely. So I'm really glad that you raised it, Koi. So let me find out more about that and get back to you specifically about it, but that's going to be important for us to also look at. And I think the wider question about what our responsibilities are is the one that we're really working with at the moment. What do those look like? Off the back of this study, we had actually hoped to apply for some more funding to do some participatory work to try to develop some approaches that would kind of enact a type of response that researchers could take to trying to address some of the attitudinal issues that we uncovered both in schools and in CCCs. And we haven't been able to take that work forwards. But I think that, there is a clear potential for researchers to get involved in that way. Although I understand we're then verging on activism. And I think, that's a big topic for this meeting.
Vicky, I'm glad you raised that. I wondered if you could say more about the role of champions in AHOS and who they were. Were they the teachers? Were they related to it? Were they in Nina's research team? Who were the champions?
So, there are different sorts of champions. There are adherence champions, are actually adolescents who are living with HIV themselves, who are adherent and who are doing well. And will work within CCCs to try to support their peers to adhere. So they act as sort of positive role models, and they're described as adherence champions. And much of the work that they do is supported by a prominent NGO that works in the area. But I was more loosely using the word champion to describe the way that certain individuals might elect to behave in that way. And so, for example, we found one really important group are teachers who are living with HIV, who themselves would, generally speaking, not be open about their status. There is an organization in Kenya which is called the Kenyan Network for Positive Teachers, Kenapote, that tries to support teachers who are living with HIV. But at the moment, certainly in our setting and in the schools that we worked in, teachers are not willing to be open about their status in general because of the stigmatization that existed. But they would work often in quite covert ways to support students that they knew were HIV positive. So, I think that that's another structural way forward through the Kenapote Association.
There was one other question that was about this presentation, Vicky, which was from Holly Taylor. Could you orient us a bit more on the level of resources available in terms of health and social services in the context of this study, just to help get a sense of the obligations of researchers to refer and that sort of thing?
Yeah, can I clarify just a little?
Yes, please.
Yes,
Good morning, everyone. I was just wondering, I was struck where you ended up in terms of identifying, can we identify and can we parse the sort of what is the researcher's obligation beyond, being respectful and thoughtful. And it seems like it's related to what the sort of baseline health and social services are available to these folks. And so I'm wondering if you could, are they extremely overstressed? I'm just a little more context about that would just be a little helpful in orientation.
Yeah, so I think the area in which inevitably health researchers feel best able to provide ancillary care support directly or even through referrals is in the area of health. So within the Kemi Welcome programme, again, there would be the possibility of providing some routine services. So things like treating acute infections if a teenager had a chest infection, or so that kind of easily manageable acute illness would probably be managed entirely locally within the research programme. Otherwise, it would be referred to the existing public clinics. And it's just really variable, Holly, so it's quite hard to make a generalisation about this. So because the neurodevelopment group have been working in Kilifi for a long time, in fact, support for quite a lot of neurodevelopmental issues has been sort of over time strengthened. So for example, things like epilepsy or general neurodevelopmental issues, there is more support for investigating that within the public sector than there would be within a typical Kenyan hospital. You know, so it's a little bit variable, but what I would note is that a lot of kind of quite common things that could be fairly easily resolved, like for example, teenagers who had sort of difficulty with their vision, the strategy there that was the only strategy that was possible was to refer them to get their eyes tested, which could be done free, but if they needed glasses, they would have to pay for them. So, you know, it's quite limited outside of the kind of healthcare things that could be done. And again, because the research program has been working for some duration of time in Kilifi, even for more serious health problems, there were often connections in place to allow referrals to kind of provincial level or potentially even national level. So healthcare was always something that could be slightly more easily supported than social care, for example. So we were kind of talking about instances of domestic violence or, you know, or any issues within the home that would be there were much less well-developed systems to support that. So this is purely descriptive, Holly. I'm just trying to give you a bit of a picture of what's going on. I don't know if that helps at all.
Well, it's very helpful. And, you know, I think obviously sort of relevant to your work in the sense that this the vulnerability cascade is likely even, I don't know what the right word be, steeper or, you know, more layers outside of the setting that you're in, right? Like it's almost the researcher obligations in your setting are, you know, a lighter lift maybe in some cases than they would be outside of a pre-existing infrastructure.
Yeah, I think that's quite right. So I think that's where there's some promotion of resilience that's potentially possible through the participation in research without wanting to, you know, make too strong a case of that.
Thank you, Vicky. I just wanted to say we can open it up now. We've got until, we have about half an hour. If you had lingering questions about the other two presentations earlier, or you think of something for Vicky about AHOS, please feel free. And in the meantime, I was going to go back to some of the questions that we left before the break, and they, I think, tie in nicely with Vicky's presentation. So one of the questions that Wendy Rogers had asked before she had to go because it's late Australia time, she wanted to know from any of the teams, what were the most surprising or unexpected unpredictable vulnerabilities that you encountered? And there was a related question from Florencia. She wanted to know more about this idea of hidden vulnerabilities. I wonder if anyone from any of the teams would like to chime in on that, unexpected or hidden vulnerabilities. Sassy, do you want to go first, or?
I'm happy to chip in unless there's anybody who wants to go first. So maybe just a couple of thoughts. So in terms of surprising vulnerabilities, perhaps something to mention in relation to chain, and we'll probably come back to this again tomorrow, was that we had frontline clinical researchers who are very experienced in conducting clinical care in different hospitals. And what they found made them vulnerable and was upsetting for them was asking questions about the socioeconomic situation of households, which they don't normally do in their clinical practice, and finding really, you know, like the stories that Rita read, finding really quite sad and difficult situations for households. And so that put them in a difficult position in terms of not knowing how far they should go in terms of offering support and feeling quite tied with, you know, what support they could offer. At the same time, they also talked about appreciating, understanding, sometimes in ways that they hadn't appreciated before, the situation of households and the enormous hard work and difficulties that many families have gone through before they've even arrived in their facility. So I guess that was a little bit surprising in a way, because we're talking about researchers and clinicians who have worked in these environments for a very long time, and they found it powerful and moving to be involved in this work, and for those reasons. So that's just an example of a surprising finding in some ways for us. In terms of hidden vulnerabilities, I guess they're everywhere. And, you know, the cascading, you know, just something relatively small in research, adding to already multiple layers of vulnerability. It could be hidden in terms of you wouldn't quite realize unless you saw how it added on to the other vulnerabilities. And just one other example is, for instance, if we were going to visit people in their homes and we've asked them whether it's possible to have a visit in a home that lasts for 2 hours, for example, sometimes people will have not gone out to work that day to earn an income in order to sit and wait for the research team to arrive, or for someone to come and talk to them to do some research activity. So that can mean that it's not actually 2 hours, but potentially a whole day that's been taken out of potential income earning for a family, which is already potentially struggling with earning enough money to even feed a family comfortably. So that's just a few illustrations, and I think we see them everywhere in our work, and we need to be looking out for them and planning for the ones that are expected in all of our studies and trying to minimize them.
Thank you, Ceci. I don't want to put you all on the spot, so feel free to, you know, to ignore me, but Anderson, Gladys, Napat, Boosie, I wonder if any of you wanted to also chip in to Ceci's point. Were there unexpected difficulties or vulnerabilities that you noticed in doing the frontline research? I am putting you on the spot, sorry.
Can I say something?
Please.
This is Florencia. Well, first, I want to thank a lot everybody for taking so seriously my work and working so hard with it. It's really, I know I don't have words to thank to all the team. It's really interesting and nice to see that what you think, it's helpful for other people. But what I was going to say was regarding this last point, Ceci said that maybe some things that are really like at the beginning tiny may deploy a lot of other vulnerabilities. This cascading idea, which I think that it also relates to the context, because maybe the same issue in a more resilient person or a little bit more empowered might not have the same cascading effect than in others. So I thought that was really interesting, but also noticing that this way of thinking things may be helpful. It's really impressive. So thank you a lot and I really feel so bad being so far and not being able to be there interacting because of this virus. But I hope someday we can meet and interact more directly.
Thank you, Florencia. It was so nice to have you join us, even if it's virtual, and we'll have to follow up and come visit you in Argentina. But your work, obviously, and Wendy's work have really influenced our thinking, and it's been really helpful and a nice example of how more theoretical work can really help shed light on and insight into really complex realities on the ground. So thank you so much for taking time to offer us your insights. Peikyung, did you want to chime in?
Yeah, thank you for all that, such rich discussions. I just want to chip in on the people taking so much time out of their daily life and losing work, etc. When participating in research, whether it's or not it's a clinical trial or a qualitative study. Very often when we put in grant applications, there's always a pushback when we ask for participant compensation. So I think this work collectively, we all can, I think it's come out in our research as well, to say that, you know, we have evidence to say that people actually need the compensation. It is unfair to ask people to spend so much time on your research without compensating people adequately. I think as a you know, this is a so what, one of the so what question. We can take this evidence to when we ask for money for compensation. Over.
Thank you for raising that, Peikyung. I wondered if Napad or Supak wanted to say something about the hidden journeys. I know you'll be talking a little bit more tomorrow about how participants in the MESOC context through politeness and graciousness might not mention the journeys, but I wondered if one of you could give an example to highlight what is really a hidden burden for a lot of participants who travel a long way.
Sure, I can add a bit more. So our participants or the clinic where our research sites are located are on the border, on the Thai side of the border. And participants are like Rachel presented, many of our participants don't have proper documents and they risk you know, being caught when they travel for work or for attending clinics or return for follow-ups. But in our study, we interviewed our participants and they, I think in our view, we would say that as a hidden burdens or hidden vulnerabilities for them. But Supak also said something about them living in vulnerabilities, you know, difficult lives, and it's a daily life where they endure these hardships. So it's become part of their lives. But if traveling long distances during different seasons also creates different kind of vulnerabilities or challenges for them. Maybe Supak can add more.
Yes, I can give you one example. The participant, she come for the interview, but because when they are well explained of the purpose of the study, they want to take part and explain you or answer all your questions so that you learn something from them. But when you realize that she still have a small child to go back to breastfeed, and as the one who interviewed, you have to decide you will not take her time longer. But with NAPAD, when we see a case like this, we always tell them, we will come back another time, and I find it positive that they want to, even though they have difficulty to come, they have to come with motorbike or come on foot, they want to come back. So I find it in a positive way that when they want to take part, it's very much depend on when you explain them the purpose of what you are doing, because they want to share with you about their life.
Thank you both for chipping in. And again, we'll hear a lot more about the MESOT context and that issue of hidden vulnerabilities tomorrow. It's nice to have some additional examples. I wanted to go back to a question that Catherine Wright raised in the short Q&A session earlier this morning. It was partly an observation of and question of how do you all think we ought to balance this need not to exacerbate existing vulnerabilities of daily living, and at the same time respect someone's agency, someone's ability to make choices and decisions even when living in really difficult, constrained circumstances. It's another hard question that goes at the heart of the data and the heart of what you all have been wrestling with. But I wonder if anyone wanted to chip in on that. It also connects to the AHOS data, Vicky. And I know Al's been really engaged in the schools in Kalifi. So maybe one of you might want to chip in on how you strike that balance of being mindful of vulnerabilities of daily living in the research context and engage young people's agency, just as an example. And Catherine, feel free to raise your hand or just unmute if I got that wrong.
That was great. Thank you very much, Maureen.
Did you want to elaborate at all, or yeah?
I think the only thing I think I'd elaborate is just there were such wonderful presentations. Thank you all very much first for that, and just really illustrating, I guess, just what an impossible job it is being the researcher in this environment, in that you're trying to avoid this idea of vulnerabilities being too simplistic and the old idea that they're vulnerable, we can't research, we're moving on from that, and recognizing the complexity of the vulnerability, having the responsibility not to exacerbate that, and particularly to think about how one's research might intersect with it, and at the same time being respectful of the agency, and some wonderful examples there of resilience and agency that were provided. So I was thinking partly of sort of the what next question in terms of what kind of support might be available to help researchers manage that kind of issue. Recognizing it will always be difficult, so how can they not be on their own? Over, thank you.
Thanks, Catherine. So does anybody want to respond to that question about balancing, even if it's just reflections on how difficult it is? Jen.
Hi, yes, thank you everyone. The presentations are so interesting. I just had a bit of a comment, I think, towards what you were saying, Catherine, that in some ways, of course, they don't necessarily need to be in tension. And I think lots of the work that the teams have conducted show how, some of the ways that you can go about remediating vulnerability would also then promote and support agency. I'm thinking in particular of the language issue that the Thai teams encountered, where the language in the hospital isn't necessarily the same as your first language. And that made a lot of the participants very vulnerable in that situation. But of course, by supporting family members to provide interpretation, by enabling different ways of communication, both their vulnerability is reduced as well as their agency being supported. That was a bit of a comment. Doesn't completely
Thank you, Jen. It's really helpful. So Jen Roost is a fellow on this project, and she's been really helpful in helping us think through how long-standing work in the social sciences on agency amongst vulnerable populations might inform research ethics. So it's a real blind spot in research ethics. So we'll stay tuned for Jen's. Jen Busi and Sassy have a paper coming out on this. So thanks, Jen.
May I add something else?
Please.
Yeah, I think that, well, I haven't seen the paper that's coming out. I imagine it is related to autonomy and empowerment. And I think these notions in this view of vulnerability are part of what we begin the session with. And it was these feminist approaches to vulnerability, because one of the issues that, it's like traditionally, vulnerability, not only it was thought as subpopulations, but also only about protections. And I think that Catriona Mackenzie, Wendy Rogers, they brought in this very strong idea of including also autonomy and agency, and not thinking that autonomy was something absolutely different. So I think that in this sense, it's very interesting. And I took the same path, but I think it's a broader, it's really, I think, a feminist way of thinking. And maybe because feminism it's really very relational, and so it's not that there are so separate things, no, that you have to bring in not only protections, which are really important, but also empowerment in order to allow people to be there and be able to be their own agents and continue. So I just wanted to add that little recognition of all a field of work, no? In this sense.
Thank you, Florencia. Yeah, the starting point for this whole project really was that feminist model. So thank you for pointing that out. There has been a lot of thought around that. I think we were referring to the research ethics guidance, which I think tends to separate out all of the work on consent and all of the work on vulnerability and risk assessment. So it's really in the guidance that I think we're pushing for there to be more of a connection. But thank you very much for that point. Rose, I wondered if you wanted to unmute. You had a really nice observation about SMRU's focus on humanitarian work alongside research, which is a unique model and an interesting model. Can I put you on the spot to maybe say a bit more about that?
Thank you, Maureen. Yes, because the population we work with are migrant and refugee, we know from just providing the humanitarian work how difficult it is to reach the clinic. So when we add on the layer of research to that, then we're really thinking how will they manage it? I've got a complaint on my last study. It's actually one of the studies that you've included here about the number of people who refused. But the pregnant woman knows whether she can come for those follow-up visits or not. It is difficult to come. So, and they have the right to refuse. So I think understanding this population, yes, the ethics committee in Bangkok says vulnerable, but those women in the studies that you looked at are really deciding for themselves what they want to do for their lives or their child, even though they don't have a word for vulnerable. Yeah.
Thank you, Rose. Yantina, you've made a couple of comments, and I just wondered whether you wanted to chime in from your experience in South Africa.
I can, if they're relevant. I'm trying to wrap my head around this incredibly vast data set and I haven't been involved in your research before, yeah. So I might just not get it, and I think I'm a bit slow because I think some of the stuff people have been saying, I'm kind of catching up. But so there's two thoughts. One is that so the idea of intersectionality, right, and positioning this any individual at the intersection of multiple identities, and then interrogating what that means for how people experience discrimination or other things is interesting. But it struck me listening and reading the chat, particularly around corporal punishment, that exchange, that there's an intersectionality between some of these concepts as well. So vulnerability and agency, obviously, but internalized stigma too, right? So that's a whole kind of different kettle of fish, which intersects with vulnerability, but it's not always about vulnerability only. And so thinking a bit through, or asking a question really about whether you've considered that, I guess, in the analysis or in the overarching work. So it doesn't come just from Vicky's presentation or Rita's or Sassie's, but kind of thinking about the way in which these various completely different concepts communicate to each other, if you will, including thinking about kind of legal concepts, ethical obligations, vulnerability, internalized stigma, and others. So that was kind of one thing, one comment I made. The other, and this is really a question, I think, to the team, is in our own work, what really comes to the fore time and again, and I'm starting to recognize it more and more, is a quest for knowledge. And I wrote in the chat that I think what we are seeing in our data is a quest for what I think is epistemic justice, a quest for being taken seriously, being informed about the research and why we're doing it. So that relates to Vicky's ideas around deliberation as one approach to qualitative research, but also requesting knowledge as an output of research, because that helps people increase their agency. It helps increase or address feelings of internalized stigma. And so it manifests in very different ways depending on the studies we do and the topics we use, the topics we are interrogating, but it comes up every time. And I think that's partly to do because of South Africa's history. So, lots of really marginalized communities that haven't had access to proper education, that have been socially, historically marginalized, continue to be marginalized. And so the research interaction is one domain in which knowledge is the thing we barter in, right? And so that comes to the fore. And I think that's one reason that manifests. But I was just curious whether that comes out in your data at all across these multiple sectors. So, for instance, Vicky, in your work, in your interviews, do people speak about knowledge and wanting knowledge and appreciating knowledge as one way of countering degrees of vulnerability and stigma, and in the data of others?
Thank you, Jantine. I wonder, Sassi or Vicky, do either of you want to take that on or engage a little bit on that? I know we've thought a lot about intersectionality in the traditional sense, familiar sense on the vulnerability side, and I think we're just starting to grapple with these other interconnections between agency and vulnerability, between the structural drivers of vulnerability in the research context and in daily life, and how those intersect. So you've caught us kind of in the throes of trying to sort all that out. So it's an excellent comment and observation. Sass, did you want to say anything to that?
I feel like it's something that I need to think about more. It's definitely something that we are thinking about as a program and as a wide network of people conducting research, is the whole area of epistemic justice and how to strive for that as different actors in research fields in different levels, as funders, as reviewers, as senior researchers, as senior researchers from overseas who are from countries who are outside local communities. So I think I would need to think carefully about how I answer this, but I do feel like at a very micro level, there is an interest to make sure that we pay proper respect and attention to the very rich knowledge that there is in local communities, and that we have a responsibility to contribute to that in ways that's helpful and wanted by people that we're interacting with, and that comes through in all of the interfaces and levels of our work, and that sometimes just having good conversations and mutual learning is something that is perhaps not given enough attention to as a really important contribution and outcome of research activities. So sorry, that's not a very good answer, but I mean, it's absolutely key, and it's fundamental to what research is, what it's intending to do, who's got the power in it, and how we transform that to be fairer.
Thank you, Sassy. Lucy, did you want to say something on this?
Yes, thank you. And I hope that you will respond to part of Jantina's question. So firstly, to echo Sassy's view on the need for respect for local knowledge systems, that came out during some of the interviews with the CABs. And I think the challenge is translating that into meaningful, actionable outcomes. I found, for example, when I was presenting the study to the CABs, that they had their own issues that they thought were of priority in the community. And here I was presenting what I was said I needed to present. And so in the end, it boils down to the power dynamics. So the agenda for the researcher is set such that we are going to look at ABCD, and the CAP are insisting on the other hand that these are the issues that are bothering our communities, and we would like these investigated. So in short, it's that tension of, and it's not just the researcher position, because at the time you present, the study has been funded and you have this set question. So it goes deeper to being meaningful about partnerships and respecting local communities. I'm not sure if that makes sense.
Thank you, Busi. Tom, I wanted to come back around to your question about COVID. So Tom Bray from Welcome has asked how COVID has exacerbated vulnerability in the research context, particularly from the field workers' perspective. And I know everyone is in the midst of working on COVID-related projects, both in the research ethics side and in the clinical side. We can definitely come back around to this tomorrow, because I think it's both topical and really pressing. But I wondered if anyone wanted to share from your site, either from Mesat or from Busi, from Samkele, or from Khalifi, how COVID is exacerbating some of the things we've been discussing this morning. Napa, did you, sorry to pick on you again. I was just wondering if you could share what's been going on at the border and how COVID has impacted research at SMRU or anybody else on the team.
I'm just going to give an overview on the COVID situation and how it affects the migrant populations. And I think, Rose, could you add more on the research? So Mesot is on the border, and then we have a lot of migrant communities in and around this district. When the outbreak came, there was an order to restrict movements, and our migrant workers, they already face lack or no freedom of movement and difficult to move around. But with this order, it's even stricter for them to seek employment, travel from one place to another, because I think in order to control the disease, the the Thai public health had put, authorities and people responsible in different areas to screen people, so people are not traveling from one area to another. And the border was also closed, has been closed during this time, and they increased strict border control. And our patients or some of our research participants come from across the border. During the closure of the border, they cannot travel for appointments or to seek care. And we've heard from some colleagues that work in different areas along the border, saying that some pregnant women who had planned to cross the border to Thailand to deliver their babies could not come because they just could not, they're not allowed to cross the border. And right now, Mesot is, it's described as a red spot because there are a lot of business going on the other side of the border. Involves a lot of Chinese businessmen and the casinos. There were a lot of Thai people that working across the border that request to return because the situation in Myanmar, it's getting a bit difficult for them to cope with. And they have been returning, and then among them, they have tested positive. So Mesot is considered quite strict during this time.
Thank you, Napa. It's really helpful to just have us even a brief glimpse into what things have been like over the past year. We'll come back around to this. I'll park it for now since we're at the end of time for today. We have a number of comments that we didn't manage to get to, and really appreciate how engaged everyone's been. It's wonderful to see, and it's so helpful for all of us to get your questions and insights into this work. So thank you so much. And thanks very much to the presenters this morning who dealt with lots of technical issues and time differences.